I asked to come down here tonight. Was nice to see some people I haven't seen in a while. Always a pleasure to be at this support group. This is basically where we started, my wife and I, when my son took sick. So seeing some very familiar faces is a nice feeling, and some people that I've been speaking to. This machine that I'm going to introduce this gentleman, once I saw it, the first abstract I saw was at American Association of Cancer Research, and it was the early abstract that showed some very interesting preliminary results out of Europe. And then it came last year to the conference out in Napa, the Brain Tumor Conference, and if you looked at this, this was incredible. Here we had, on a small study, some patients, and this, I think there is one patient still out, a very long time, and another patient right after that for a nice amount of time. And we have a novel therapy here without it hurting anybody. And as all you guys know that are dealing with this, that's what we're looking for. Anything that can help us, anything that could give us another chance to extend quality of life. And I'm just totally taken by this. I hope it continues to prove out for all of us. Mike Ambrosi, I've met along the way. I have no financial interest in this. I am very impressed with this type of medicine. Al Musella is sitting here, the gentleman that runs the virtual trial, the most important internet service we have. He's very interested in this to get it out to everybody. It's on his side already. It hit CNN, I believe, or some station in Chicago when they signed the first patient. Mike just told me they just signed the 20th patient. It's in 17 centers, about to go possibly into the 18th. It's very exciting. Mike will show you, from what I understand. I saw a presentation recently. This is going to be a little different than the one I saw a couple weeks ago. I had Mike come up to the board of the Brain Tumor Society just so I could have the board see this. I've seen it a couple of times at different conferences, but a lot of the board members hadn't been there, and they were very, very impressed with this. I only hope that you consider this therapy if, God forbid, you need it. It's Michael will explain when and where this could be used and when the time is right for you. And this is a very nice gentleman who talks our language and is very concerned for our health. And he represents a good product, so he talks with confidence. Mike Ambrosi. Thank you, everybody.
Thanks a lot, Dennis. It's really an honor to be introduced by somebody who's done so much for so many, certainly with Dennis. And thanks to Stan and Patty for organizing this tonight, and thank you for giving me this venue to talk about our new treatment. As Dennis said, I'm Mike Ambrosi. I'm the U.S. General Manager for Novocure, and I'm here to talk to you tonight about a new type of cancer treatment. And specifically tonight, we're going to talk about its application for recurrent GBM. We don't feel the treatment is limited to that, but that's what we're going to talk about tonight. I have about 15 or 20 slides. Should take about 20 minutes to go through this. Please ask questions along the way. That would be great. And we'll have time at the end for some Q&A as well. But this is where I need to give the big disclaimer up front. Everything I'm going to talk to you about tonight is for an investigational treatment. It's an investigational device. It's not approved for commercial sale in either the U.S. or Europe. It's investigational or in clinical trial, as Dennis described. So I just need to let you know that up front. Why do we need a new type of treatment? Well, the fact of the matter is that the current treatments have some significant limitations. As you know, anybody who's been treated for a brain tumor knows that the treatments with chemotherapy and other radiation treatments have a hard time targeting just the cancer cells. They also have an impact on the healthy cells. So as a result, it creates some toxicity issues. There's limits to how much dose you can get. And also there are some significant side effects associated with these treatments. And the bottom line is that as far as GBM is concerned, glioblastoma, the efficacy, there's room for improvement there. And so we're looking at a new treatment that can provide a difference there. Our treatment in general, we call it the Novo TTF. TTF is Tumor Treating Fields. So it's delivered by a medical device. So it's not a drug, it's a medical device. And it's designed to disrupt the cancer cells as they replicate. As you know, these tumors can grow very fast, and so those cells are dividing quite frequently. And this device is designed to disrupt that process and kill off the cells as they divide. And what I'm going to talk a lot about fields. these tumor treating fields. So let me just take a little diversion here for a minute and tell you about fields. The best analogy I can come up with is a magnetic field. You know how you can take a magnet and a magnet can pull on something even though it's not touching it, like a piece of metal, and it can push on a piece of metal depending on whether it's positive or negative? Well, that's a magnetic field. We can create an electric field with electric circuits, much like a magnet can create a magnetic field. And the electric fields can push and pull on things that have electrical charge. So that's what we're talking about here, is these fields we're going to set up around the tumor to prevent the proper replication of the cells. And I'll talk in more detail and show you some movies, about how that actually works. And the benefits of this treatment are that because we can target just the cancer cells, there aren't dose limits with this. We can essentially provide a continuous treatment 24/7. And we have reason to believe from the pilot study that we've done so far in Europe that there's promise for improved efficacy, specifically with respect to recurrent GBM. And the interesting thing about this treatment is it can be used in conjunction with what's already out there. It doesn't need to be an instead of. It's not as if, let's pick this chemotherapy regimen instead of this one. This can be done in addition to, which makes it, I think, a new tool, for the cancer fighters. A little bit about the company. We're formed over 6 years ago by Professor Yoram Palti, as Dennis mentioned, who's a very prominent scientist in Israel. And Professor Palti has put together a very experienced team of scientists, engineers, and clinicians to bring this to market. And based on the strength of his early scientific work and his reputation, we've put together a scientific advisory board that includes 2 Nobel Prize winners, as well as several other prominent scientists. The company's based in Haifa, Israel, but we have operations in U.S. and Europe to support the clinical trials. And so I run the U.S. part of that operation. All right, so a little bit more detail on how tumor treating fields kill the cancer cells. Again, remember, we're talking about electric fields, and they act on electrically charged particles, just like a magnet would act on a metal particle. And these cancer cells are dividing very rapidly. The cancer cells will divide, these glioblastoma cells divide about every 24 hours. So they're dividing quite rapidly. And the healthy cells are dividing every couple of weeks, once a month, if at all. So there's a pretty big difference between cells that are dividing every 24 hours and ones that are dividing very slowly in a matter of weeks, if not months. And so as a result of this rapid division with the cancer cells, they develop certain electrical characteristics. And remember, we're dealing with electric fields, so those electric fields act on these electrical characteristics. So it turns out the electrical characteristics of the cancer cell are different than the healthy cells. And we use this low-intensity electric fields to act on these cells, and I'll show you here what I mean. And I emphasize low intensity. We're not cooking anything. It's not a microwave. You can think about certain types of your microwave is essentially an electric field that happens to act in a certain way on the molecules to heat it up. That's not what we're doing. We're at low intensity, just at a specific frequency that happens to disrupt this cancer cell division. And what happens here is, as this cancer cell is trying to divide, this is a picture of a cancer cell dividing. It wants to split into 2 nice little pieces there. And these lines represent the electric fields. And if any of you have ever looked at a topographic map, you know that when the lines get really close together, the hill's pretty steep and you better walk around. Well, that's the same kind of thing here, where these lines are close together, particularly here right in the middle. The field is very strong there. The field, what we call field gradient, is very strong there. So there's these organisms, these structures inside the cell, organelles and macromolecules that have electric charge. They're part of what happens in the cell division. Well, where these fields are very strong, it's pushing and pulling on these things right at this critical juncture. And that's at a time when the cell is trying to divide, so it's relatively fragile at that point. And what happens with this electric field, this cell will actually break apart. It won't be able to pull apart. And let me show you what that looks like. So here at the top is a picture of a normal cancer cell division. There are no tumor treating fields around it. And it starts out as one cell, and the H there represents hours. So in a period of 3 hours, it splits into 2 nice, neat little cells. Down bottom, there's 2 sequences of pictures for cancer cells that are in the presence of these tumor treating fields. These are, microscope blow-ups of what's happening in a cell culture dish. And you see here, as this cancer cell tries to divide, those electric fields, again, are pushing and pulling on all those structures inside the cell, and it actually breaks up into many, many pieces. And those pieces can't reassemble. They can't reassemble and live on. They'll die off and be absorbed into the body. So that's what we're actually doing, is we're preventing the cancer cell from doing what you see in the top line. So let me show you. I'll actually have a movie of this. Let me show you what that looks like. All right. So this movie is stop action photography. This clock is every hour. You'll see a circle here around a cancer cell that's starting to divide, and it's going to break apart into pieces. Here's a good one here. You'll see it breaks apart into pieces. There's one right here, and just breaks apart into many pieces. There's a real good one coming up right here. And it's trying to divide, and it breaks up into all those pieces. And again, those pieces can't live on. That's cancer cell destruction at the cell culture level. And that's the science behind what we're doing. So now the question is, how do you turn that into a therapy, right? Okay, it works in the cell culture dish, but how do you turn that into a therapy? So here's what we've got. Our therapy works by delivering these electric fields through non-invasive electrodes that we place around the tumor. In the case we're treating brain tumors, that means on the scalp. So you see here a representation, let me go back a second, of those electrodes. These are the electrodes on the head, and they look like bandages with wires coming out. They stick on the surface, and they have these wires coming out so we can get the tumor treating fields into these electrodes so we can get those fields around the tumor. I have some examples up here we can look at later. So the patient wears these electrodes around the tumor on their head. The head has to be shaved so we can get good contact and be able to get enough energy in. And then those connect to a box. It's a small, portable, battery-operated box that they can carry around with them. It's like a heavy purse. I don't know how heavy your purse is for the women in the audience. My wife's purse is pretty heavy. It's not a whole lot different than this. It's 6.5 pounds or so. So this box here provides the tumor treating fields and has the power source that goes up the cord, up to the electrodes that are on the patient's head. And as a result of that, we can provide continuous treatment. It's portable. So 24/7, we can provide this treatment. Now you think about the cancer cells are trying to divide all the time. They don't go to sleep at night. So we need to have those fields there when they're trying to divide. And because there aren't toxicity issues with our treatment, where we're worried about damaging the healthy cells, we can do that. We can treat them literally around the clock with this. Now the patients can get a break for convenience sake if they want to stop the treatment for a while, but in general we encourage them to keep the box on as often as they can. And what the patient feels, they just feel their head get warm. That's all they feel, because we're putting energy in, so it provides a little heat, a little warmth. And in the wintertime in New Jersey, that's not such a bad thing. But we're not conducting electricity to the surface of the skin. These are insulated electrodes. We're just setting up the field. The magnet is pulling on something; it's not touching it. And so it's not like you're going to get shocks or feel tingling because you're conducting electricity around. It's not like putting your finger in the socket. We're just setting up the field. So all they feel really is warmth on their head. And you could put a hat or a wig over that, but that's how we deliver the therapy. So we've been developing this for over 6 years. We went from cell culture experiments to animal studies. We've been on patients for over 3 years now, with some pretty encouraging results out of our pilot trials for recurrent GBM in Europe. So in that pilot trial, we more than doubled the overall survival of our treatment group versus what we call a matched historical control. We didn't actually have a control group in the trial. We used sort of historical data for patients with similar types of diagnosis, and we more than doubled the survival there. But the more important thing is, 2 of these patients are alive and feeling well more than 2 years after they started treatment, and they're off the treatment. One of the patients, there's no evidence of a tumor on the MRI whatsoever. That's what we call a complete response. So over a period of 8 months, her tumor went away, and she's alive and doing well. And in the study, the only adverse effect of the therapy is skin irritation under the electrodes. Those are warm, there's moisture up there. Skin irritation will develop, and you could treat that with topical creams. There were no unanticipated adverse events. There aren't any systemic side effects associated with the therapy. So it's a pretty low-risk venture from that point of view. I have a few pictures. So here's the woman who had the complete response. So these patients they're recurrent glioblastoma. So they had their surgery if it was indicated. They've done their radiation. They had their chemotherapy, most likely Temodar. And then some of the patients have had multiple recurrence. They've had several chemotherapy regimens, and the tumor keeps coming back. The case with this woman, she's been through all that. The tumor comes back, and over a period of 8 months, we can't see it anymore. It's a 100% reduction. There's no radiological evidence of the tumor being there, and she's feeling good. Here's another picture of, again, a recurrent tumor. This one's fairly large. That's the baseline when we first started treatment. And when I say we're starting treatment, at this point in time, they're not doing anything else. They're just doing our therapy. I did mention at the beginning that this can be done in conjunction with other treatments. In this case, for our study, we're doing just the treatment. We need to prove as clearly as possible that we're having an impact. And so in this case, after 5 months, we see a 40% reduction here. And these are fast-growing tumors, so even just to stabilize the tumor is an event in itself. So to be able to get that kind of reduction, we think, it leads to, some promise. So armed with that information from the pilot trial, we visit the Food and Drug Administration in the U.S. and we get approval for a large-scale study to really statistically prove if this early promise is real or not. And that's what we're embarked on now. So we have a 20-center trial. We're targeting 236 patients. This trial is across both the U.S. and Europe. To be eligible for the trial, you need to be 18 years of age and have recurrent GBM. And you need to be able to have reasonable functional capability because you have to be able to manage the box. So that's another requirement for being in the trial. And if you're in the trial, in this case, we do have a control group. So half the patients are going to go on the treatment, and half the patients are going on the best standard of care at that institution. And in that case, the best standard of care, in this case, gets a whole lot of follow-up because any patient in the trial, whether they're on the therapy or the best standard of care, is seeing their physician on a very regular basis and getting very close follow-up. And in that case, they're getting the best standard of care available at that institution versus the treatment. So we have people in both groups, and then at the end, we're going to compare the data. Again, we're doing this center at leading cancer centers, including New Jersey Neuroscience with Dr. Landolfi and Patty right here in our backyard. And I'll give you the list of centers here in just a minute. And the Novocure pays the cost of this trial. So the insurance picks up some of the coverage, but the Novocure will pick up the balance of the expenses associated with the trial. If you're a patient on the device, here's what life looks like for you. The first 24 hours of the treatment, you're in the hospital just for observation. So we start up the therapy, you stay overnight, make sure everything's okay, and then you go home the next day. And then there's monthly follow-ups with the investigator. And then you have an MRI every 2 months, that's the standard practice. But the key thing here is that twice a week, we need to replace those electrodes. And the reason is the hair grows back pretty quickly. And as that hair grows under the electrodes start to lose contact, and then we can't get the energy in. So what we have to do is twice a week, we take the electrodes off, reshave the head nice and clean, and then put a new set of electrodes on. The electrodes are disposable. So what we've done is Novocure has set up technical centers to do this. We make it as convenient as possible for the patient. Either they come to our center, which we try to put in good locations and entice you there by whatever means we can. If not, we go see you in your house, and we'll make it as convenient as possible for the patients. And here in New Jersey, we have a technical center in Englewood Cliffs. Elisa Vinyas mans the center, and she's out visiting the patients and taking care of them twice a week. So there's quite a lot of follow-up in the study, again, because we're replacing these electrodes twice a week. And we've developed quite a support system as well for the trial. We have 24/7. We have a round-the-clock support line that's staffed. Elisa is available around the clock as well. And we have very good follow-up with the patients. So. The clinical trial sites. We have quite a list of, prominent list of investigators. Dr. Phil Gutin at Memorial Sloan Kettering is the principal investigator for our U.S. sites. And Dr. Roger Stoop is a principal investigator for our European sites. You might recognize Dr. Stoop's name. He conducted the important clinical work that led to today's standard of care for primary GBM, the Temodar and radiation. He was crucial in that, so he's well known for that. Again, as I mentioned, Dr. Landolfi here at New Jersey Neuroscience Institute. Here in the New York area, we're working with Dr. Bruce at Columbia, and we're also working with Susan Panulo at Cornell Medical Center. Not all these sites are up and running right now, but they will. The ones that are not will be soon. And we're working with Cleveland Clinic. Dr. Engelhardt at University of Illinois is a big recruiter. Dr. Kushner at Allegheny Medical Center has a few patients already, as does Dr. Reiser at Northwestern. So it's a pretty good lineup. You'll notice that it's somewhat geographically constrained to the northeast for the most part. We're not in California, we're not in Florida, we're not in Texas. And part of that reason is because of the heavy hands-on content of the trial, we have to manage that, and it's easier for us to do that in a constrained geographic location. But we will be adding other sites potentially over time. So if you or someone you know is indicated for the trial, recurrent GBM, I recommend that you learn more about it. We have a lot of information on our website. We do have an 800 number you can call. We have here tonight, and we'll put them out, We have a patient information sheet that has a lot of good information on it, including a list of centers. There's also a list of centers on our website. And we also have some pens, I think, and magnets that have the website name on them. So I'm going to encourage you to learn more about it. Again, as I mentioned, no significant side effects. We do see some promise for GBM. So thanks a lot for the opportunity. I appreciate it. And that, while we believe this treatment is investigational, we do think that it does have a lot of promise for the recurrent GBM patients and hopefully for other types of cancers as well. Thanks a lot. Great.